Good afternoon, everybody, and welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. The meeting is broadcast on the Council's YouTube channel, Hillingdon London, and my name is Keith Spencer. I'm the co-chair of this board. And as usual, some housekeeping before we start. So please ensure any mobile phones around you are on silent. That particularly applies to me, who forgot from the last meeting. We're not expecting a fire drill, so if the fire alarm does go off, please follow officers out of the building. And as usual, please keep your microphone muted when you're not speaking and then unmute to speak. And it is worth noting that some of the members of the board may be using devices to access the agenda and papers for the meeting. So everybody's happy, we'll move on to the agenda. Apologies for absence. Nikki, do we have any?
Chair, we've had apologies from Councillor Jane Palmer. We've had apologies from Sharon Stoltz, Sheikha Sharma's here as her substitute. From Vanessa Odlin, Claire Eves is here as her substitute. And from Julie Kelly, Alex Coman is here as her substitute. Richard Grocott-Mason and Professor Ian Goodman.
Thank you, Nikki. Again, any declarations of interest in matters before this meeting? Nope. I'll take that as no. So if we can move on to minutes of the meeting of the 2nd of December 2025, does anyone have any comments on the accuracy of the minutes? If not, are these agreed? Obviously, those of you who were here at the last meeting. I will take silence as consent. Thank you. Right, so, and then if I move on to the exclusion of press in public, I can confirm that items 5 to 10 will be considered in public, and items 11 to 13 will be considered in private. So everybody's okay. I'm going to move on to the Integrated Health and Wellbeing Performance Report and Service Update, and I think, Sean, you're going to lead this for us with backing vocals, I think, from Gary on this one. Thank you.
Thank you. Yep, I will take us through the report, and then any other questions or partners that need to come in to go a bit further. I suppose I'm going to just take the fact that it's quite a long report, so what I would do is probably just focus on some of the key highlights as summarised in the executive summary. And I just wanted to note that actually I've included some of the definitions of what some of the different areas mean and aim to do, and it was put in last month. It's just for continuity of people that are either new to the meeting or watching for the first time. It explains it a little bit more. So the report is structured around the progress against the 5 priorities of best start in life, live well, age well, healthy places, equity inclusion, which are all supported by major transformation programs. And looking over the executive summary, the overall position is showing the system is stabilising and starting to reflect some measurable improvement, particularly in discharge performance, frailty management and mental health crisis flow. However, that performance does remain above operational targets for emergency department attendances and overall bed days used at the hospital. And the scale of change required to lock in sustainable improvement has not quite yet been fully delivered. Some of the key improvements that we've had, first is probably just a note on winter resilience. Compared to winter last year, and looking at the period from September to February, there's a clear improvement in acute performance. That in relation to ED attendances at Hillingdon Hospital were reduced year on year by 4.6%. Overall 12-hour waits have reduced by over 35%, and the 4-hour performance has improved by 8.5%, and that actually places Hillingdon amongst one of the strongest performers within North West London in those areas. And I think the message here is that we are starting to get some good grip and control measures and able to work under the pressure we're in. Second, the other area is probably focusing on flow and discharge, and we refer to the term no criteria to reside. Now this does relate to the patients that no longer have a medical reason to be in hospital. And actually, if you look at the work that's happened there, there's been some material reductions in the overall number per day of those patients. Before we picked up some of the work we were doing, we used to hover around the 50 per day, which is 50 patients a day that didn't need to be in hospital. And through all the work we've done over it, you can see the 10-week average that we've had since then is around 36. So there's a really big improvement and change there. This is supported by daily multi-agency GRIP with lots of meetings and people meeting taking place, actually discussing the patients and the processes that take place there, with a weekly gold oversight meeting to actually really look into the areas where we can support as much as possible and make the movement on the areas that we're struggling with. And actually this has started to sort of translate into some improved bed availability and overall flow. And probably the third area just to focus on is some of the frailty and preventative care work. As we know, we've got frailty case management, and we're now covering around 50% of the severe frailty cohorts. And we've got some early evidence that we've been able to reduce down some of the emergency admissions for those type of patients. And actually this is one of the reasons that matters. It's a key foundation to reducing future bed day demand, supporting those patients to avoid needing to go into hospital. Probably linked to that, and it's not in the report because it's quite a new one, linked to that is some of the care home information that we've had. And actually if we compare activity coming from residents that are within care homes, and now these can be quite frail patients, you know, a bit older, need a bit more need and support. We've had about a 25% reduction on A&E attendances in relation to patients coming from care homes this financial year compared to the previous financial year, and actually around 33% reduction on the admissions made. And there is a lots of work that's been going on across all partners on sort of care home support work, going out to the care homes to support them and give them education and training, and I think we're starting to see some of that come through there. I suppose I would say alongside the progress that we've made, we should probably focus on some of the areas that we remain off track, to highlight those, and ED attendances is still one of those areas where we're above the operational target, although we have seen some improvements there. If we look at the January average, we were seeing around 176 patients per day, compared to the targets that we're aiming for, around 164 per day. And then the other places, whilst we are seeing a reduction in some of our overall non-elective patients, and these are the patients that are going unplanned into hospital, we are seeing that we have a pressure in relation to the overall bed days. So it's the length of stay that patients can stay, so it's the patients that are there for longer than one day, and so they're the areas that we need to sort of look at to continue to support. Over the next 3 months, I think we're framing it as sort of consolidation and acceleration, and not really focusing on new initiatives, and that is to sustain the work that has taken place and embed that further in relation to the criteria to reside patients, continuing to have that below 34 per day, translating the frailty coverage into measurable bed day reductions, and then fully mobilising and supporting some of the other areas, so some of the reactive care work we've done. So we had the coordination hub that stood up in December, and it's around seeing that through into the further phases, and then showing alignment with other areas like virtual wards and neighbourhood teams, and then strengthen some of the community alternatives to ED. So there's some of the other things that have come online since we had the meeting previously, is we've now got mobile diagnostics. It's that improved flow through from GP to SDEC pathways, and continuing to move with some of the other areas that we've had, like pharmacy first. So probably without going too far within it, because I can leave questions for people, there are, towards the end, there are quite a few areas under the appendices, and that focuses on some of the actual specific changes, elements that we've brought in since we last met, and that actually shows you some of the achievements that were made within there. So we've got the Lighthouse service, which was a revamped model that went live in November. We've got the mobile diagnostics, as I've already mentioned, and some further detail on the no criteria to reside, and then a couple of schemes in relation to Best Start in Life around the transformation we're doing with the CYP Transformation Board, which we met last month, and we're looking to move and change that as we go forward. So overall, probably to conclude, we are seeing some genuine measurable improvements across the system. But we need to ensure that we continue that work as demand does remain high. And I think we need to embed fully some of the elements we've done, because we're fragile on some of the areas, but we've made some really good improvements. So over the coming months, we're going to focus on protecting and locking in the progress already made, reducing variation, particularly in some of the discharge and neighbourhood delivery work, and turning some of the early programme impacts into sustained system-wide performance improvement. So I'll pause there, and if everyone's got any questions from anything they've seen, please.
Sorry. Thank you, Sean. It's probably just worthwhile saying, so when Sean refers to our operational targets, they are the targets locked into the hospital redevelopment programme, and that's what we're tracking. And I think, Sean, what might be worthwhile bringing to the next Health and Wellbeing Board is just tracking where we are against those targets, because I think it's quite helpful just to see exactly where we are against the whole range of those hospital redevelopment plans. It's particularly important because obviously one of the things the ICB want to come and talk to us about in June is where are we against some of those redevelopment targets. And as Sean says, we're making progress, significant progress into a range of issues. Still some way to go, but it's that long-term length of stay that is proving particularly intransigent, which we need to try and think differently about, I think, going forward. But I think, thank you for that report, Sean. I'm going to, Leslie, do you want to bring in terms of hospital observation?
It's not often that I'm asked to speak louder, but thank you. Thanks, Nicky. So I think we've managed to secure that. The two bits of it is that helps us with some of the patients that come up very often. The other bit that I think we should work on, building on the work around the frail elderly, are those patients who are looked after either in nursing homes or dom care, and use that money to actually underpin that service to do even more in the community, because those are the patients in the end who stay the longest in the hospital beds. So I think building on that would be a really good idea. But genuinely and generally, I just wanted to say thank you to all parts of the system, because it has been a system response that has allowed us to get to where we are. Thank you.
Thank you, Leslie. I'm sure the committee wants to note and welcome the progress and improvements at the hospital. I think there has been a significant change in. I think that we now have a shared narrative, I think, and an honest and frank relationship, which I think is to be welcomed. Questions, observations from anybody else on this? I mean, what I would say, probably just to back Leslie up on this one, but it's a bit early in the process, going to the place board tomorrow are some of the lessons learned from the No Criteria to Reside work, and it would be helpful just to see some of the case studies where things didn't quite go right, and some of the challenges we've had around complexity in particular, where people really have got very complex needs, and we've had difficulty, I think it's fair to say, in helping them to be discharged from the hospital.
Absolutely. So in general now we talk about complexity. Most times we're talking about dementia, not every time, but most times. And I think actually saying what we mean is something that I think we need to get to, which is therefore how do we plan for those needs. The other place, and I I'm raising this nationally, this in the national work, because it is a national problem, but is an issue here, is those patients that are admitted but then have no recourse to public funding, and where that responsibility sits, because particularly sometimes if they need ongoing care, nobody wants to take any responsibility, and I get why, by the way, I'm not, but I do think that needs to be clarified nationally, that says what is the funding and what is the pathway that needs to be used, because it's a growing issue. But just to say we are raising it.
Anybody for anything else? This is our main performance report as a place, so any concerns, observations, I think now's the time to raise them. We have a scrutiny committee next week on the same issue. So I think the message here is we're doing well, we're making progress, we're tracking against the new hospital redevelopment numbers, but it's important we don't peak too early in this one, and that we sustain what we do. So I would like to add my thanks to the work of partners around this table. Those gains have been hard won, I think, by a lot of hard work from a lot of people. So I am personally grateful for the work that partners have shown in working together. And if you ever want to know how partnership working really affects, do come to our Thursday evening place goals. It is it'd be an entertainment sport, that is, as well. You've been there, Sandra, so you've been subject to it as well. So, but thank you, colleagues, for the work that you've done. So,
I would jointly agree with that, actually, if you wouldn't mind placing that on the record.
Thank you.
Thank you.
So, so if we note that report, and thank you, Sean, I always found that clear, and I think we've got to a stage now where we've at least got one version of the truth, and as Alan McGlennon says to me, I recognise those numbers, so at least we know they're the same numbers that we're all working off, which anyone who's worked with health numbers will know that's no mean feat. Okay, follow that, Gary. Let's move on to the draft Joint and Health and Wellbeing Strategy update.
Thanks, Chair. The board actually approved the draft health and wellbeing strategy at its December meeting, subject to consultation with residents and other stakeholders. The purpose of this report is just to give the board an update on progress with that. So in short, we've partners have produced plain English summaries of the strategy, and there is a variety of mechanisms for engaging and consulting with residents and other stakeholders, including online surveys, staff surveys, using existing resident groups and partner communication networks. What the report is asking the committee to approve is that we bring the results of the consultation process to your June meeting, and that meeting is then asked to approve the final version of the Joint Health and Wellbeing Strategy. Take any comments, Chair? Thank you, Gary. Any comments? I mean, it's really for noting, isn't it? The consultation engagement is in process as we speak. It's the versions are on the council website. From a staffing point of view, CNWL are hosting the health consultation from that side. So it is a piece of work. That's right. So yes, place partners are consulting with their own staff. There is consultation underway with council staff. So we've done that in two ways, which is basically staff who are residents of the borough, but we've also done some targeted consultation of those members of staff who work in social care, that's children and adults. Okay, can I just check that people are content? Do I have to approve that what Gary is asking for is approval to bring the consultation back to the June board? Do I have a mover and seconder on that?
Yeah, agreed. Fantastic.
Thank you. And then Gary, why don't you carry on and talk about your favourite subject, the Better Care Fund? Yeah, so this report actually provides the board with an update on the requirements of for the 26-27 Better Care Fund.
This is sort of within the context of the government's intention to reform the Better Care Fund. So this is 26-27 is a sort of interim staging year. The intention is to align it more with neighbourhood health plan targets, which was actually reiterated in the neighbourhood health framework, which was published yesterday. To make the board aware that there's actually been a small increase in the minimum value of the Better Care Fund for 26-27, which is 43.48 million compared to 42.70 in 25-26. So that's a 4.4% increase of the minimum contribution to adult social care, and a 2.1 increase for other aspects of the minimum NHS contribution. The mandated funding streams that come directly to the local authority remain at the value that they were in 25-26. The plan will actually have 3 mandated targets attached to it, or three metrics, which remain the same as in 25-26. So it's a reduction in preventable admissions for the 65 plus population, discharge delays, and permanent admissions to care homes. There is an additional metric that the planning requirements are asking us to look at, which is reablement specific. It's not a formal metric for 26-27, but it's quite clear that we're getting a steer for 27-28, and that's really regarding the number of people discharged from hospital into reablement who are still at home 12 weeks after discharge, and that's on a 12-month rolling period. How we've actually approached this, Chair, in previous years, the board may recall, is that we've actually delegated approval to the Corporate Director for Adult Social Care in consultation with members of the board. The actual submission date is the 19th of May. What I propose is that we bring the draft plan to the board for final approval at its June meeting, which is scheduled for the 9th of June. I'll close there, Chair, for any comments.
Thank you, Gary, for that. I think it's probably worthwhile just saying, Sandra, and some of the conversations that we've had, is in the light of the changes happening, particularly to the NHS, and we'll talk about this a little bit later on neighbourhood health, there's a need for us to collectively review what we spend our Better Care Fund on, and the priorities at the local place. And I think we need to make sure that we build time in to do that before presenting that to back to the board. Because I think although the ICB are proposing a roll forward in that, I think actually, given the scale of the transformation we have, I think collectively we might just want to review what we're spending that on. And I think, Sandra, we've had some brief conversations on that.
Yeah, I agree. The roll forward position doesn't necessarily meet our local kind of position at the moment in comparison to lots of others, although there is lots about it that can. I just wanted to reiterate the 4.4% is inflation, and obviously everybody knows that that's considerably less than the actual inflationary costs. So the uplift in the BCF is actually not going to purchase more, in effect. So people don't get the impression that that's actually going to be, we've got slightly more money than we had last year, because of course we have, because it's going to cost more to deliver those services. And the 12-week metric is a metric for reablement that's been in existence forever in terms of ASCOF. So it was the 91-day metric before, which is now 12 weeks, the same thing. But it is a really good measure, and I think that we perform really well against that as a system. So I think it's good for us to monitor that and keep a good eye on it for the future, and fully utilise our reablement services for everybody being discharged where we can.
I think it's probably worthwhile also saying, obviously, in terms of the work we're doing as part of the reactive care work, we are just looking at the interplay between rehab and reablement and what the opportunities are for, bluntly, productivity gain in terms of that. And I think that's an opportunity I think we're wanting to pursue as part of that. Gary,
just to say on the reablement metric, there are some differences to the previous metric, the still at home 91 days, which I think it actually makes it a better metric, and we have also included it as a measure within the draft joint health and wellbeing strategy.
Leslie.
Thank you. And we had a discussion about this at the National Discharge Group this morning, actually, and not so much about the issue we're going into, because I think in general there's a feeling that people are trying very hard and having to meet the sort of demands that you just described. And I think there was a thing, and I don't think it applied to Hillingdon probably, because in relative terms Hillingdon performs very well. But there is something that says, actually, if we have those metrics, and people don't make any progress towards those metrics at all, what is that better care fund being used for, and what's the point? So I think we ought to at least prepare ourselves in terms of looking at those regularly, that says actually we could answer that question, forget there, but here, because actually I think here is a really good example of how it is used pretty well, and to the right. For the right reasons and to the right things, but we should be sure that is the case, because potentially we may be asked to say what's the approach here elsewhere, because some other places it's clear that the Better Care Fund isn't being used for what it's set out for.
Yes, Sandra.
So I think it was 2 years ago, Keith very helpfully did a review of the out-of-hospital services for North West London as part of the BCF usage, and I think our reablement services have performed really well over time and continue to do so. Where we've got an additional opportunity now is to build on our bridging care, build on our therapies, working with Claire and the rest of the team to actually have that both admission, prevention and discharge set of services that keeps people at home. And I think that dovetailed with the work, and I have to say it's a good opportunity for me to call out the teams that have been communicating, particularly from the Confed and other areas, with the care homes around keeping people in situ and having the mobile diagnostics has been really communicated well now. It took us a bit of time, but it's really been communicated well. We've got experience of it in some of our own care homes as well as some of the others. I've seen some of the lovely videos that are demonstrating. I think we should put on websites and make sure people are seeing it. It's really positive, and it's positive for the system, positive for the hospital, but it's really positive for the patients and the residents. So I think we are making really good progress in that area.
Any other comments on that? So I think what we're hearing, Gary, I'll just check with board colleagues. It's yes, bring that back to June's meeting, and what we've just made clear is that obviously what we need to do is to make sure that what we spend the Better Care Fund on reflects the priorities of the place in terms of what we are trying to achieve here. I say that in confidence because I know it's something we would do anyway, but I think it's actually quite important because actually quite a few of the gains that we've made this year are due to how we've flexibly used the Better Care Fund to fund things in the past that we wouldn't have used the Better Care Fund to do, and I think that is really important for us going forward.
Sorry, Chair, can I just ask, so is delegated authority also needed? No.
Okay, I think, Alex, I'm sorry, I should have welcomed you to the meeting. Alex, you're here to talk about the occupational therapy service as update. Can I invite you to speak to the paper?
Thank you, Chair, and hello everybody. I believe this report was tabled at the last meeting and it has been heard, so apologies for that. This is just a reiteration of that with some updates. Bring it a bit more up to date. I will take the report as read because I know it's been shared before a couple of times, so I'm not going to go through a lot of details on it. But just to say that the purpose of the report is to update this forum about the OT delivery for children. And you would have seen from the report that this was raised based on the last academic year, where 400 children who had occupational therapy as part of their plans have not been receiving consistent contacts or sufficient contacts. That has been addressed. This work has started between the CNWL, and I believe, Claire, you're working with Gary, who's the head of commissioning in Children's Services, to look at how that's going to be addressed. Now, that work has been progressing for a while now, and there's been various things that have been done already at the beginning of academic year. A recovery plan has been put in place. A joint recovery plan has been done by CNWL and Children's Services. And those children who had no contact at all have been prioritised, and to make sure that through separate commissioning arrangements they started receiving the OT sessions. Also, any other therapeutic needs have been assessed and been prioritised and planned into the children's plan and timeline. And also, the ambition was for all the children to have appropriate level of contacts, of OT contacts, by the end of March. And as an update, I think it's fair to say that that's been broadly achieved, and there is a temporary capacity in place at the moment. There's been agreed through CNWL, apologies, and the local authority, and that has led to vast majority of children who have a priority need for OT contacts having received the OT contacts. Also, there is through this temporary capacity that's been created, there's been a reduction in pressure in terms of casework, in terms of caseloads, and that is also positive. Let me just bear with me. So I think as another, the introduction of the agency staff and various ways of meeting that demand has led to every school to have a name-linked therapist at the moment, which is really positive. Also, the OT are looking at key areas of development, looking at risk mitigation, looking at service stability, and looking at workforce resilience. And all of this has led, as I said, to making sure the majority of children who require the OT sessions are receiving those at the moment. The link planning meetings continue to be delivered to all schools, which means that every school will have the benefit of having a clinical risk assessment for those children who don't receive face-to-face OT contact. And also, I am aware, and Claire, please correct me if I'm wrong, there is the funding is in place until the end of March, and there is ongoing work at the moment between CNWL and the local authority to put in place for the remainder of this academic year, and also, I think more importantly, to have something in place that's sustainable by the beginning of the next academic year. I'll take any questions.
Thank you on that. Alex, so I might invite Councillor O'Brien in a moment to speak, but so if I've got this right, it seems to be, and it sounds like good work has been done, good joint work has been done. There was a demand versus capacity issue, which we've rectified collectively in year. Additional temporary funding has been put in place, and how we substantiate that for next year is currently broadly under discussion. Claire, do you want to come in first, and I will invite Councillor O'Brien to talk?
Yeah, thank you, Chair, for allowing me to respond. Yes, so we have seen a significant increase in the EHCP plans over recent years, and that is in the national picture as well as just local to Hillingdon. In the last 8 years, Hillingdon's seen a 90% increase in families receiving or requiring an EHCP plan. That's whether that's a non-EHCP plan or a EHCP plan. The contract is jointly commissioned by the ICB as well as the local authority. We have over recent months seen a vacancy rate that's again impacted on our ability to deliver to some of these children, but also compounded with the increase in demand. So we there hasn't been additional funding. What we've done is use the vacancy money that we had to bolster this with agency staff. They have been in place this spring term. I have had agreement from CNWL to extend that till June. So we will. This is reducing the pressures on the caseload. Staff morale has improved, as you can imagine. The pressures and the retention of staff within the OT team has been difficult to manage. This is an improving picture. We've also put in, as you've said, an OT technician as a point of contact for all schools, and also we've got linked practice opportunities meetings which are delivered with Senko. So each child is reviewed, and then those that are needing any further complex reviews, they are undertaken as a priority. I'll open to questions.
Thank you. So to make sure I've got that right, we have it, given that we're in the middle of March now, we haven't quite bottomed the recurrent funding beyond June. Have I got that right?
No, so the current funding is from our current vacancy rate, so there isn't any additional funding at the moment. I'm continuing to, it is purely the occupational therapy team that are struggling to see all the HCP plans.
So it doesn't sound stable to me. It's
stable as it is. Ongoing, to secure ongoing funding, we need to work with the commissioners to decide how we're going to take this forward. I have got an external consultant coming in to review the service to see if there's any further efficiencies that we can make and streamline some pathways, and from that report we will take that forward.
Susan, any views from your good self?
Thank you very much for the opportunity to comment. I think it became abundantly clear to me at the latter part of last year that there was a number of academic year. As soon as those sort of changes happen, my inbox starts to fill up, and by the time they obviously want to reach the cabinet member, they've gone through so many conversations and pathways and managers and stuff like that. So it was definitely with a concern for me at that point last year. So it's good that we're back and we're having a conversation. I suppose you said we know that we will funding stops in March. We have keeping capacity as best as we can, subject to obviously workforce, of course, because that's the biggest problem out there. That doesn't get us to the end of the academic year, so I don't know. I'm hoping that we don't end up in the same. I think last year was a much more stressful situation because it started a lot earlier. But between that last part of the summer, that summer half term at the end, it will be interesting to see how that works out. So I'm hoping that the commissioners and the local authority and the health authority are able to just pan that out, and then we have to then start on the following academic year. The positive thing is that our SEN strategy has changed slightly, and again, I think we all just have to focus on making sure that the children and the young people that need it receive it, and just continuing to work through. But this is no mean feat, and I fully understand that. I think everybody else does around the table, but it's been able to deliver on a promise as such. Thank you.
Claire?
Respond. Yeah. So going forward for the rest of this academic year, we will have the agency in place, and that has been confirmed by CNWL, and we have just done a really successful recruitment campaign and offered to those vacancies. So I think we're in a much stronger position than we were. However, I think we just still need to discuss around the demand and the capacity that we are continuing to face.
So this feels unresolved. Sorry, Leslie, yes. Yeah.
This is from a lack of knowledge maybe, but sorry. Can I just ask a couple of things? In any other specialty where we have seen a 90% increase in demand, you'd say that would have to be an epidemic actually, or so that there is something that says have we done enough in terms of the education of schools and teachers and things like that about actually appropriate as well? And the second bit is, given that, if we accept that level of demand, and again, this you're much better well cited on this than I am. What have we done? So if we were having anybody referred into hospital by our GPs, you would prioritise by acuteness of illness. And I don't know if that's possible with these children or not, but if it is, are we triaging that and doing it?
I'm happy to respond to that. Yes, so with an EHCP plan, where Section F of that plan is stipulated to deliver a certain number of contacts, that is a requirement. It is almost like a prescription for that child, and so that is the number of contacts that has been asked of us to deliver, that has increased significantly within the OT realm, and that is where we're trying to work through. Obviously, we look at all the complexities. We skill mix. We've looked at different prioritising children where, as you say, the need is greater. So we have explored those. We are continuing to have conversations with the local authority and the ICB on where we go forward.
Yes, Amanda.
Again, this is almost certainly lack of knowledge, but it sounds like it's not an activity-based payment, or is it?
No, it's just a block contract.
Block contract.
Yeah, as in, yeah.
So within the new strategy, Chair, there's talk about some filling in some commissioning gaps and things like that. So I wonder whether this might be one of those services. Is that a possibility?
Yeah, and I think what we can say is with the reforms, I'm meeting with Abby and Alex next week around how to fully understand what those reforms will bring and what payment, if there is any extra resources. Also the way in which the schools are being expected to support with some of these EHCP plans will be changing. But that is for a conversation next week.
Yeah, I was kind of thinking specifically about the West and North London information that's coming out. Part of the 1% left shift includes, I think, 34 million for next year for that is for filling gaps identified across the system. And it's possible that that's one of them. Yeah.
Hi, Alex. Yes, come.
Yeah, if I just very briefly on that, in terms of the increase, 90% increase over 8 years, and the significant increase of the ACP plans in general, that is definitely not a Hillingdon issue. It is not a London issue. It's national, as we all know, and we all rehearsed that quite through various other forums. And in terms of, I think a point that it's a really good point about what happens in next year and the reforms that came out. So the SEND reforms have been published about 4 weeks ago. There's been a raft of publication that came out of the FA that we are still looking at distilling. What do they mean? How are we going to meet some of the demand? And we have to produce our plans to submit those to the FA imminently in terms of how we're going to be responding to the reform. And meetings like the ones that Claire mentioned about looking at jointly how we're going to be responding to everything that came out at once are happening as we speak. And we've tried to move at pace to see what that means for various other provisions. And some of the things that have been introduced by the reform that we didn't have before, they will have to have joint commissioning available to meet those requirements. It's a very dynamic landscape at the moment, and there's a lot going on, and obviously with the amalgamation of the ICBs coming on stream as well imminently, all of that has to be kind of looked at in together. So I think having a financial solution and an interim financial solution for this academic year, it's actually a really good position to be in, because that gives us that buffer to be able to distill everything and to see what that means for our children starting September.
Tony?
Thanks. Didn't want to disappoint you, Keith, by not saying something. But just a couple of points on it, really, and I'll sort of speak a bit more bluntly about it. And to your point, we hope the reforms do bring something in terms of threshold point, actually, because there's no motivation for schools to do anything differently, because the funding to date has been carried by the local authority through the DSG, which has been ring-fenced to this point. That's all moving on. but nonetheless, unless something changes in the criteria, it'll just be the bill that continues, but the volumes will continue because there's no change in motivation for people, so it's really only a threshold point. And so hence the discussion that's been going on about whether it's about PIPs, whether it's about EHCPs, it's the what's included within current threshold levels. So there is a lot to do, because I can't see anything that's been published so far that is going to make a difference to the volumes, make a difference to where the funding's coming from, but the volumes, which are obviously going to impact on health services, are still going to be there.
Summarise that. Okay, so what I've heard from Alex and from Claire is that in effect we have a holding position for the remainder of the academic year. There's a range of conversations that are taking place outside the meeting, which may or may not address the underlying issue which Tony has just described. What I suggest that we do is obviously we bring this back in June in our meeting, because that appears timely for the end of the academic year to review where we are with this. I can't think of anything else to add to that unless anyone else has got any wisdom around the table on this one.
I have no wisdom.
Do you want me to comment on that? Okay, with that, if we take that as the action, Nikki and Alex and Claire, thank you for that, and we recognise the difficult position all partners are actually in on this, but let's see where we get to in June, when the commissioning landscapes of both health and local authority hopefully will be a little bit clearer, given the change that we're all going through. Okay, if that's okay. Samrin, do you want to give us is you're on the agenda? Do you want to give us an update?
Thank you, Chair. I was hoping to do a small presentation, but I think it's not getting connected. But if a verbal update, yeah. So I'm assuming everybody knows who Health with Hillingdon is, so I'm not going to dig deeper on what we do. Today I would like to take this opportunity to present our patient experience and entry view reports that we have collectively done. Just before I begin, I just wanted to say how all local health watches are structured. There's a difference. Some are operating independently and individually by themselves. Some sit under a parent organization. So since August 2025, there has been a change of provider, and currently Health Watch Hillingdon sits under the provider Your Voice in Health and Social Care. So under Your Voice in Health and Social Care, we have 4 major work streams: patient experience program, entry and view visits, information and signposting, and 2 deep dive research studies that we do by talking to external partners, and at the same time by collecting intel from the residents that we go out and speak to. So since October to December 2025, we have spoken to multiple people, and we've collected around 324 reviews across GP practices across the Hillingdon Borough, and also by going to community events and speaking to people there. So based on the feedback that we've received, I have accumulated... Oh, perfect. Okay.
Right, do you want to? Press the arrows.
Okay. It's not working. It keeps going.
Oh no.
There we go. Where are we? It's not showing in your here. Okay, but I can see. Okay. Is it going by itself?
Okay, let's try.
I think it's okay. Let me just give you a verbal update. Yeah.
Okay.
Where are we? Yes. So our patient, like I was saying, our patient experience program provides a snapshot of how local services are performing based on real experiences that are shared by the residents. And I was saying that we've collected 324 feedback from people by speaking to them from the time of October to December 2025. So based on these reviews, we have charted down a few of the key findings about GP practices mainly and the hospital services, which we have summarized in here. And this is just a screenshot from the report that we have yet to publish. This is a draft one. So based on the feedback that we've received, most of the key areas come to the key areas are around access and clarity, where we've seen that patients still face long telephone waits, and many struggle with the online consultation forms. On the contrary, a lot of people have said that the online process is kind of quick and easier for them. The struggles remain around for people who are older residents or who face digital barriers. But at the same time, when I move to other areas, people want clearer expectations around how appointments, either whether they're going to be same day, whether they're going to be urgently based on and scheduled, or whether they're going to be clinical callbacks on the same day, are allocated, and better understanding of the wider clinical team, which still remains low because people would like to know who they're being seen by apart from their GPs. So I think that might be an opportunity for us, for the GP practice to build trust if they start promoting the wider clinical team besides the GPs and the doctors that the patients are getting seen by. Moving on to the hospital ones, the key themes around here are kind of the same, where we've seen strong collaboration between the staff, and the culture that the staff share has been seen to be quite significant, as we've received many praise for staff attitudes and communications, which are consistently being praised with the number of people we've spoken to. However, waiting times, particularly in the A&E, cause uncertainty, not so much of the wait, but because of whether they will be seen by the doctor and when will they be seen by the doctor. But I suppose this is a national case, not just particular to Hillingdon. Patients also told us that real-time updates would make a big difference. They want clearer timelines for follow-up appointments, so they understand what to expect and when they would be called or they would be seen. Based on our findings, we have come across our recommendations which reflect what the residents have told us. For the GPs, we have come up and said that they could optimize their telephone systems, simplify online consultation forms by either providing digital guidance or making it more clear on how to fill the forms. They could improve the transparency of the appointment pathways, like I was saying, by promoting the wider clinical team, whether they would be seen by a GP or a doctor or anyone else within the PCN or within the practice. For the hospitals, we want to encourage the continuation of supporting strong staff culture, strengthen communication during the delays, particularly in terms of getting appointments and getting seen, improve their triage flow, and provide clearer information about the appointment timelines. Then we have the Enter and View program, which is mandated for us, and this is where our lead authorized representatives, which is usually our trained volunteers or staff, they go to visit care settings and observe care, speak to residents and staff, where we look at three primary things: the quality of care, resident well-being, support for people with complex needs, and staff workload. Overall, the Enter and View has been extremely well received by the providers, and both residents and staff have been very open in speaking to us, and the providers have welcomed an independent, constructive lens to their everyday practice. For this cycle, we have focused on nursing homes and assisted living accommodations in Hillingdon. So we have been able to visit 3 care homes and assisted living accommodations until now, but we have only been able to publish 1 complete report from our website with the provider response. And the other ones, which is the Drayton Village Care Center, is the report has been sent to the provider and we're still awaiting a response from them. So our recommendations are based around our observations on the day of our visit, and also from what we've heard from the staff and the residents there. In both the settings, so the themes around how we kind of recommend what we have seen and what we have heard from the people is around accessibility of the house, the environment, the activities that are being provided to them, communications, friends and family, the staff support and well-being. So in both the settings, we have identified practical recommendations or practical improvements that can be made quickly. For example, if you see the accessibility part, we have recommended that clearer and more dementia-friendly signage, improved entrance and navigation for visitors, and better orientation cues throughout the homes. That could be, that's quite simple to put in and navigate around. At the same time, for the environment and cleanliness bit, some of the residents have, and even based on our observations, there have been issues around odor in some of the care homes, and there have been issues around cleanliness in some of the main hallways. So we have raised that with the provider, and they have seemed to taken that into consideration. There has also been shared sentiments around activities and engagements within the care homes that where the residents would like more family engagement and they would like more outdoor activities. Although the weather doesn't really permit them to use their gardens at the moment, but there could be lots done if these residents who are staying here for like a long time have outdoor trips or go to community events. That helps them to step out of the house, because they don't like to be confined in a house 24/7. Nobody does. And for a particular care home, which is the Barfield House Nursing Home, when we have spoken to staff, they have expressed that they need support during palliative care days. So we have gone back to the provider and said that they could use this feedback in terms of providing them with emotional support or continue with rotational staff rotation, so that carers or staff who are particularly supporting people with palliative care, they do not feel drained out at the end of their shifts. So we have a project coming up for this year, and our ideas for this project come from various sources, from the patient experience feedback that we get, from hearing from all of you here, from Northwest London Health Watch Networks, Primary Care Executive Groups, Health Watch England, patient reference groups, and the activities and the community outreach we kind of do as part of our remit. So there is a hospital discharge project that's coming up for us, where we're trying to capture patient experiences post-discharge. The rationale behind it was that people still experience unclear communication and inconsistent support when they transition from one service to another. So understanding the local experiences will definitely help us identify what is working well, what could be improved, and how to make discharge reliable and more supportive for residents in Hillingdon. So we are carrying out a dedicated project to understand people's experiences after leaving the hospital. So our focus would be on safety, communication, and continuity of post-discharge. We want to also look into the clarity of discharge letters, the communication tools that are used by the hospitals when the patients are discharged, how follow-up instructions are understood by them, any medication information that's been shared with them, and any digital or written tools that are provided to them while they're getting discharged. We would also explore the communication methods that work well for residents and where communication could be improved and the transition made clearer to them in a more supportive way. And we also want to hear from people's experiences once they return home. So we would be doing a follow-up conversation with them once they are at their homes, where there have been any gaps in their understanding post-discharge. So first, how we plan to do is we want to go and speak to the people in the discharge lounge of the hospital and collect their consent to recontact them after they've been discharged, so that we can get back to them and ask about how their process has been so far ever since they've gotten discharged, whether there's been any lack of understanding from their end ever since they got discharged, or whether there has been any whether there has been any good practice that we can identify or any barriers that we could highlight by speaking to them, so that we can ensure that services are supported. We can ensure that the patients are supported once they return to their homes. That's all the brief update that I have from Health for Hillingdon. But we're happy to have any discussions or suggestions from your end, as we would be planning our next financial year and we'd be looking into more projects. If you have any priorities that we can take into consideration as we speak to residents, we're more than welcome to receive feedback.
Okay, there's a lot there that we need to unpack, isn't there, I think. So obviously it's the first time I've seen the presentation. So I think there's 5 areas, if I may, and I will talk to people in turn. So 1 on primary care general practice, around access and experience. 1 for hospital, again around access and experience. Care homes, access and experience. And then the proposal around hospital discharge review. And then the final one, I think, was around suggestions for priorities for the next year. So if it's okay, if I am just going to pick on people, just to give some initial thoughts and feedback. I'm going to start with you, Leslie, because you put your hands up first.
Thank you. So lots of good work, and I think fine. Just in terms of the discharge, are you looking at people with complex discharge, so not straightforward discharge then?
No, we're looking into people.
You won't see them in the discharge lounge, is what I was going to say.
We're going to go there and try to speak about communications first, whether the people who are getting discharged from the discharge lounge, either they're present there or the relatives or the carers. So we're going to imply multiple work streams here. So we have a carers group that we want to speak to. We want to go to the hospital and see who's getting discharged on the day. So it's going to be a long-standing project, and we're going to find people in the discharge zone if anybody is getting discharged at the moment, or is anybody due to get discharged later down the time.
So we won't do it in here, but 80% of 80% of patients won't go through a discharge allowance and have that sort of they'll just go because they're just patients who are being discharged.
Mm-hmm.
So anyway, we can do it out here, but let's have a discussion about how you get the information that you want to get.
Absolutely, sure.
Sure.
Okay. Can I go to general practice next? Sorry.
The discharge. Well, because part of that piece of work is actually looking at about community services as well. So this is a piece of joint work that was commissioned between the council and the hospital. But as I say, part of it is to actually look at the understanding of the services, understanding and experience of the services being provided by community providers to assist people to leave the hospital.
So that would lead us to the complex cases then, wouldn't it, in some ways, probably, in terms of looking at, not always, but largely it's going to be the complex cases. That's the point.
And also part of that is because of one of the discussions that we're having around the pathway 1 discharges, returning people to home with support. So we've produced a new leaflet which will hopefully give people more of an understanding of what's actually taking place, and part of this work will actually test how effective that's actually being.
Okay, so we just need to connect that, don't we? Because we could end up with wires that don't connect. So I think if... Yeah. Okay, so what's the action that you need? Because obviously what Leslie says, can we just confirm who we're talking to? Because if it goes out of the discharge lounge, it's people with complex discharges.
Yeah, so I'd say, Samarine, you've been speaking to
Claire, Deputy Clinical...
to Claire and Sophie.
It's Claire and Emer.
Can I suggest we have a conversation outside just to make sure you get the right, we connect this up in the right way, so it's useful to us when we come to review the outcome. Sandra, did you want to?
So just about the care home point, it's good that you're going in and doing those visits. and it should dovetail alongside the local authority's quality assurance team that monitors all of the care services in Hillingdon. So you've got some findings that have come out of that. Do they get relayed to the quality assurance team?
They do get relayed to the quality assurance stream, to CQC, and also the providers. And this is also published from our website, which is publicly available for anybody who wants to read. So the first report has been relayed to the quality assurance team because we have decided on these care homes or the places we'd be visiting with consultation with them and the CQC.
Yeah, I can see that there are 2 homes that we contract block beds with. Good. Thank you.
Primary care, yes. Kim.
To be honest, results entirely consistent with what I would expect. So a slightly mixed bag, you know, some positive, some negative on access, talk about the phones, as I say, entirely as I would expect. I think in some respects the technology is not the issue there, though. I mean, you mentioned the cloud. You said in the notes, despite the cloud telephony, that's because actually the issue is the volume of calls that you get, and GP practices simply don't have enough, despite all their best efforts. They just don't have enough staff waiting on the phone to actually deal with the volumes, really. So they are using the technology effectively and increasingly effectively, and in fact the Confederation, through the transformation managers, support them to use all of the technology as well as they can with the callback functionality and all of that. And most practices are actually using that to almost the largest, probably not 100% of them, but there's been a significant improvement. In fact, that's tracked in the access metrics that are reported into the ICB. We can see significant improvements over time. The trouble is the demand is just very significant, and so actually it's really just about managing patients' expectations, because it's unaffordable to have people sat on the phone waiting to deal with phones, and actually waiting to deal with calls. And we are trying to move people more to the online route. Again, that's something that's been tracked significantly through the access metrics. But of course, as you quite rightly say, that doesn't suit everybody, and we need to make sure that all the appropriate channels are available to patients for them to choose. It's a bit of a difficult and slightly unresolvable problem, to be honest, because actually we need to use the money that's available to GP practices to have doctors, nurses, other clinicians available, and use the technology as best we can. That includes the telephone and online. So it's a bit of a challenging, not that we don't keep thinking about it, but it's challenging for practices.
It's interesting, because I think one of the challenges, and we'll come on to the model neighbourhood health discussion a bit later, there are 3 challenges we've been given as part of this. One is how we transform primary care access, and then the others are largely on urgent and emergency care with that high user cohort. So I wonder whether, you're right, Amanda, there's no magic bullet here, but it is something we are going to have to tackle, I think, as part of the transformation that we've got. And I think there's nothing that we haven't heard. I think users haven't told us before, but I think it gives us pause to think differently. And maybe about one of the asks, I'm thinking about what some of the asks might be going forward. We might want to think about different ways of addressing primary care access, because as we know, it has an overspill into ED, into UTC and all of that as well. So I do think it's really helpful, and I think it's worthy of us thinking about that creatively, about how we might look, because the ICB are inviting us to think about what is needed to de-risk some of the hospital redevelopment in the next 12 months or so. So we might just want to think about that. But it's a really helpful conversation, and the digital exclusion bit in particular has come up quite significantly. Alex, yeah, come.
Thank you very much. Just a very quick question. Thanks for the presentation. And having looked at the work streams and all that sort of thing, not necessarily an issue with that. What I would just kind of like to ask, just to get a bit better understanding. We have about 80,000 children under 18s in the borough. What's your sort of engagement with children? So in the planning for next year, how do you think of doing that as well? Because all of this strands that we're talking about apply across the ages. Obviously not care homes, but we have children's homes. You have mental health. You have A&E admissions. You have discharges. You have various issues at birth. You have various sexual health issues. There's a lot going on in the landscape of health for children. So how is that factoring into what you're planning on doing?
We're still in the point of time where we're still looking into what we can take up as projects in the next year. So nothing's been finalized or fixed yet. So this is where it starts. Talking to all of you, talking to our external partners, we would be aiming to do a survey and talk to residents across the borough. What do they think are priority areas? Where should we focus in the next year? So part of our patient experience program would be looking into speaking to residents all across the borough, that ranking from priority areas. Where do they think we should focus on, and how should we collectively do a piece of work to support them? So if that's a suggestion for us to go forward with next year, we're happy to take that on board.
Great, and I think that sort of engagement, the co-production, makes absolute perfect sense. The only sort of thing that maybe we can have a conversation outside of this with myself or someone working, in social care, if you like, is how are you going to be doing that engagement with the residents, because that sometimes is quite difficult. So if we're talking about children, who don't necessarily speak English, children who don't necessarily engage with questionnaires and communication, adolescents, various areas that we've thought. I'm just wondering if any kind of thought has been given how that's going to be done, or indeed experience in other parts of London or the country, and also potentially using some of the engagement groups that we already have, where our children are telling us a lot of things, and that potentially could be a link into the work you do to get that voice of the children as well as the voice of other residents you are engaging with.
Yeah, so there's been established community groups that works with children, and we are in touch with them. And there has been a piece of work done by Health Watch Hillingdon, by the former provider, on children and young people's mental health. So those resources are still there, and those connection points are still there for us to kind of access them.
Amanda?
Yeah, I was just going to say, certainly from a personal perspective, I think what would be quite interesting to get some input on is traditionally hard to reach groups, because actually in driving up some of our performance, for example on hypertension, the really challenging groups that are just not very difficult as healthcare professionals to reach, understanding from them directly, getting their voice into what would get there, that would be brilliant, if there was a way of getting to that.
Sure. Is there any particular area you would like to focus on?
I'm thinking of like Hayes and
the neighbourhood.
Yeah, that sort of West Drayton, so, because I think there's a danger with patient engagement that you always get the same voices, people that are willing to put their hand up, and actually I want to hear from the people that are not putting their hand up, not coming into practices, not coming to engagement events. I mean, we do stacks of you're involved, we do a lot of that stuff, and there's a danger of us always getting the same people, and so if there was a way of, we try to break into that, don't we?
Sure, I seem to sense a more targeted approach.
Yeah, that would be great.
More than happy to take this conversation.
Yeah.
That would be really helpful, because I think buried in the bowels of Sean's report, we don't do as well as other London boroughs in terms of engagement with Asian groups and those. So we do need actually to ask them what is the best way to engage with you. So asking people, I think that's a really good idea, Amanda. I think that we really ought to follow up on, because we had a lengthy discussion this morning at operational leadership meeting about that issue. Alex, yeah. Susan.
Yes. Thank you. This is a comment probably more as a user rather than, and looking at your slides with regards to communication and Amanda's comments there about communication as well. I suppose what I hear from my experience, I have a good experience. I am digitally able. My children are digitally able. My 91-year-old mother is most definitely not digitally able. And I think what I'm missing with not just with the is the consistency of the communication. One surgery will not take any phone calls all day long. Another surgery will take all your calls all day long and are very happy to deal with that. My mum's surgery won't allow her to book an appointment online. If she wants to, she can only book an appointment online. If she doesn't, the option is to turn up between 8:30 and 10:30. And for a 91-year-old woman, that is not necessarily the best time of day, although she's probably been up since 3 o'clock in the morning. 8:30 in the morning is not the best time. So I think it's, and it's interesting, you know, there were so many positives about communication. There were so many negatives about it. So it's clearly, and again, we've been talking about this for very many years. It's just that how do we move everything, or the numbers of people, the 50% that are negative, into the actually it's not as bad as it was, and you're already doing that work, but it's just trying to keep that consistency across the board. I don't know if that's assistant or not.
Thank you, Councillor O'Brien. I'm a bit concerned that you've got practices not taking phone calls all day long and some that are not allowing bookings. I think they shouldn't be I don't think they're allowed to do that, if I'm honest. So it would be, if there are specific examples, very happy to try and pick that up with them, because there's a lot of monitoring that goes on of that, not by us, but through the ICB and nationally, so that shouldn't be happening. So if there are specific examples, I would hope that they are very much the exception, but we should definitely look to address that.
Alex,
yeah, very last point with with the risk of dragging this conversation, but it's something I think it's kind of important to say about the communication engagement and how do we reach all the relevant communities in Hillingdon. And we all know that in Hillingdon there is a very different picture in the north of the borough, in the south of the borough. Engagement is different, services are different, and potentially willingness to engage is very different in terms of the residents. And I think just one thing that I would say in terms of how do we engage with people who are not necessarily English is not the first language, not necessarily communicate in writing, not necessarily, you know, have trust in authority to communicate, because that's another thing considering the backgrounds. And one thing that I think sometimes we potentially fall into a trap of saying that if someone speaks a certain language, we're going to be writing a letter, translating the language, send it to them. Quite often we find that people who are not speaking English, they don't necessarily read. They don't necessarily read in their native language as well. So sometimes that makes it quite difficult, and there is a stigma attached with that. People are not necessarily always going to say, "I can't read" or "I can write" and things like that. So I think that automatic assumption that because someone is from a certain country, they will speak a certain language, they will read that language, sometimes are not accurate. So I think it's just about the difficulty. I think we don't need to. We shouldn't underestimate the difficulty of reaching out to those communities and to reaching out into a way that it's inclusive and it addresses everyone's needs.
Thank you, Alex. Okay, so if I try and summarise what I think, in the spirit of being helpful, and I just wonder, Gary, just in terms of the health and well-being strategy work, two suggestions. One is, I'm assuming we can take this feedback as feedback against the health and well-being strategy, because that's exactly what we're doing, unless you think we ought to do something different. But it would seem, given all this feedback you've given us, we use that as a driver for...
Just to say that Sam Marine Health Watch Hillingdon colleagues are actually supporting us with the consultation on the strategy.
Lovely, thank you. That answers my question. So, what we've done, I think in terms of the suggestions to be helpful, Sam Marine, I think we've had, obviously, there's a joint piece of work around discharge, which you've already got. And then I think the ask, which I think is an important ask from our perspective, is, I think as you summarise that, is is how to engage with groups who are finding it difficult to access health services. I think would be because, to be honest with you, our numbers aren't as good as they need to be, and we can sit in a room talking amongst ourselves about what the best way to do that is. But I'd rather, as you suggest, we go and ask communities themselves. Would be really, really helpful, I think, on that. So is there anything else people want to add to that list? Yes, Sheikha, please do.
Samarina, I'll be happy to have a conversation with you about where the needs are from public health perspective. Instead of adding to your list, perhaps we can have a dialogue and then look at priorities.
Claire?
Yeah, thank you, and yeah, great presentation and great feedback, but I think from my perspective, community is not featured in some of that feedback, so I would really like a conversation outside of here of how we can engage community services and access to the community services.
You're right, Claire. I think some of that work around urgent community response, the reactive care piece, how people are finding that would be really helpful, I think, in doing that. And then the final action, I think, is that you're going to have a conversation with colleagues at the hospital just around the right focus for the discharge work that you're going to do. Can I just ask on that? Sorry. People are discharged from our community units and from our mental health units as well, and so we ought to think about the whole lot. That's a really good point, because we have particular difficulty discharging from our mental health beds, as those of us on Gold Call know frequently. Yeah. Claire? Yeah, I would welcome to be part of those conversations, because community services do support with many of those discharges, so would welcome that conversation too. Thank you, and the work that you've commissioned. Interested. Okay, thank you, Sammy. That was really helpful, and I assume we'll have a copy of the presentation, Nikki, with the minutes. Thank you. That's great. Okay, should we move on to the final agenda item on this part of the meeting, which is the board planner, which is attached to the papers. I think what we've just agreed to do, Nikki, is to add the feedback from the health and wellbeing strategy consultation to the June meeting. Also, taking a further update on the OT, the children's OT bit. Gary and his Better Care Fund approval, I think, will be on that list as well. Anything else from people around the table? Nope. Good. Take that as noted. So that is the end of the public part of the meeting. Thank you to those members of the public watching on YouTube. And will everybody please remain silent while Democratic Services have confirmed that the live broadcast has ended and the loop has been switched off. Thank you.